It's really tough to introduce Dr. Calvello, actually, because I've known her, like many of the other people here, for so long. But I'm proud to say that Emilie was a graduate of the famous Johns Hopkins University, where she was a resident. And then you later moved on to University of Maryland and then to Denver. But there was short stints of working in South Africa with the University of Cape Town, working with WHO as a consultant. And since she agreed to do this talk, she is now permanently based with the WHO team under the stewardship of Terry Reynolds. Emilie is not only phenomenal at thinking through health systems issues, but she has a way of simplifying health systems challenges and creating conceptual frameworks that have now made emergency care and the spectrum of emergency care accessible to all of us. And I remember, being at one of those AFAM consensus conferences, and there was all these building blocks in different colors and how like the health system impact of emergency and critical care relied on all these different constructs. And then it all merged into a rainbow and it all came together. And I think, Emilie, for me, that was the first time where I felt health systems literature, health systems thinking was really accessible to me. Before that, it just felt overwhelming, and it was easiest for me to focus on a particular part of the system, which, during my early career was mostly triage. So thank you for enlightening us. And I think that leads to the talk today, which is around the WHO Emergency and Critical Care Toolkit. And I think one of the biggest shifts that we've had in emergency medicine is we've stopped discussing, nobody cares about emergency medicine because we don't have a disease, to everybody should care about emergency medicine because we are from point of illness or injury all the way to definitive surgery or surgical or critical care, and possibly even home-based care and telecare. So I'm going to hand over to Emilie, especially for the fellows. I think the knowledge you get by understanding the WHO ECC toolkit, hopefully you'll be able to apply into the jobs that you do next. I'm going to have to apologize because I'm going to have to sign off on my computer and then come back on my phone, but hopefully you'll have a meaningful discussion. And then if folks are around towards the end of the session, we would love to hear where you're all ending up next year and what's happening with everybody after fellowship. So Dr. Calvello, over to you. And thank you so much.
Thanks, Bhakti.
Super late right now.
That's okay. All good. I really wanted to actually be here, especially for the fellows, and because I remember that early on in my own career, it was really difficult to access WHO people and know what they were thinking and ask them questions I thought was important. And I will definitively not have all the answers, but wanted to make sure that I was available to you guys. So it's a small group. So I'll ask you guys just to actually just jump in, please. And I'm going to go ahead and get started to share my screen. But Bhakti's story is very funny because I still use that rainbow slide. And I will tell only one anecdote that I think it was that same conference, Bhakti, if you're still on and listening, that we were coming up with advocacy phrases to see what was most salient and would be most resonant for ministers of health. And I believe Dr. Hansoti did say emergency care is barrier protection for death. So I still use it because it's quite poignant, but you have to pick the right audience. Okay. All right, let me get over here to sharing. So Bhakti asked me to speak on the WHO Emergency Care Toolkit, which we have done an enormous amount of work around, and there's much, much more to do. So I'm really happy to bring you guys into this conversation and give you a kind of deeper orientation to the tools and where some of the places of where we're headed. I didn't have quite enough time to be able to give you slides on all of that, but I can at least kind of point us in the right direction and then again, take questions at the end. And really the toolkit is demonstrative of, I think, the WHO approach right now, which is really trying to figure out how to bring emergency care for everyone, everywhere. So you all are all fellows. You did this for a reason. And some of the faculty of ON who have been doing this for quite a long time have seen an evolution over the last decade of work. And I'm going to map that evolution a little bit for you within the WHO just to give you some orientation. But we know that health emergencies occur everywhere on a daily basis, whether or not there's an organized and well-resourced system present to address them. And that was first a long time ago now in 2005 by Olive Kubsinye, and now is being echoed in our literature, because we see this in every country that we go to, and in the ones that are asking us for help from the WHO side, that no matter what their system is, we are seeing that these health emergencies are causing a lot of death and disability, and we'll get into what those numbers are. But to just back up a second and seat you guys where I am in the WHO. So I am a technical officer, and my department is Integrated Health Services. This department is actually relatively new. So we had a process called transformation in WHO, which was a big reorganization. And that sounds like a lot of bureaucracy, but it was quite important to bring the universal health coverage agenda into some kind of functional being. And so that was some of Dr. Tedros's early work in kind of reorganizing WHO to make that happen. And so when that transformative agenda happened, we got seated here under universal health coverage across the life course is what it's called. And then in this department called Integrated Health Services. So within Integrated Health Services, there's lots of different things that are incredibly important for delivering health services, including IPC, the patient safety flagship, quality of care, health service performance assessment, and actually traditional complementary and integrative medicine. And we are sat, right here in clinical services and systems. Oh, I'm having a lot of trouble with this tonight. And really what clinical services and systems is about, I'll tell you a little bit more, but it's designing clinical management and integrated health services at all levels. That's kind of the basic descriptor. Interestingly, actually, WHO had not done this before, in that most of the time service delivery was addressed in vertical disease pillars. So this was the first time they all got kind of brought under one umbrella. Just to orient you guys on the timing, that happened in 2018 and into 2019. And actually that whole CSY unit didn't get stood up until I think it was late 2019. And then you know what happened in 2020. So immediately CSY was inundated with the tsunami that WHO and the rest of the world were, which was the management of COVID-19 and how clinical service should be responsive to that. So we're essentially just coming out of that massive surge and back into what the scope of work was originally intended. So here's clinical services and systems. We call it CSY. It includes primary care, emergency and critical care, and operative care. And really the whole orientation of the unit is around integration of those services, like Bhakti was talking about, and the organization of those services with both packages of toolkits and things that we can do to kind of bring better service delivery, particularly models of care and how those services are delivered across the health system, and then particularly clinical pathways. Ones that CSY right now is particularly concerned with are things like trauma care and sepsis care that cross across the different domains. But then there are other things that are cross-cutting that are enormously important within our unit, like palliative care and the role of hospitals within a primary healthcare agenda and approach. So that's a lot to talk about, but just to, again, to give you a little bit of an orientation. Ultimately, CSY is about amplifying the impact of WHO normative guidance. And this is my favorite line about it, and this is why I took the job, because it's aligning the reality of frontline service delivery with the user's needs. And it's that reality where we work as emergency clinicians. And a lot of times I feel like when I have read WHO documents in the past, they just have not made a lot of sense for exactly what this means about the reality that I'm seeing in front of me with my patients, wherever I am in the world. So when I had the opportunity to transition and come here, I certainly jumped on it in order to see what we could do about bringing emergency care into that reality. So oftentimes when I'm giving this talk, we actually start with, in our regional trainings, around what emergency care is. I know you guys know this. I'm asking you to take a step back and receive it as with fresh eyes, essentially. Because if you try to give the elevator pitch in one sentence about what emergency care is, or you tried to explain it to your parents when you were first starting to choose your specialty, it's incredibly difficult, right? Because you're like, well, I do trauma and I do sepsis and I do pediatrics and I do geriatrics and I do sometimes, chronic disease management and refills on medications. So it's all these things, and it's also the safety net. But if we at WHO understand it in this way, and this comes out of the World Health Assembly Resolution 72.16, is that emergency care is an integrated platform for delivering accessible, quality, and time-sensitive health services for acute illness and injury across the life course. So let's just dive into that for just a second. Again, pulling out themes that you guys know from your primary experience, but maybe packaging it in a little bit different way to give you kind of some novel insights about why this is so important. So when we talk about accessibility, clearly there's one that's just like, okay, yeah, we're open 24/7 and we do shifts all the time. But the way we are really trying to expand thinking about that at WHO is about not only availability, right, but accommodation. What is it that the patients need to be able to come into that space? Is it affordable, especially in places where there's huge out-of-pocket payments? Is emergency care actually acceptable to the population? I spent a ton of time last year, and you'll hear a little bit more working in Afghanistan. There is a whole host of acceptability issues around particularly women coming to the emergency units. So we're thinking about access in a much more holistic way. And of course, we're familiar with quality. I mean, sure, quality is important. You guys have, whatever your performance measures are in your own emergency units. But what does that actually mean when you translate it into resource limited settings? How can we maximize our ability in the constructs of new emergency care systems to have them be explicitly patient-centered? And what does that mean if you could start and create them in the way that you always wanted to, not in the way that the U.S. Health Service has done it or in some other systems that you've experienced. But if you were advising, right, if you were dreaming up kind of what would be the best utilization of emergency care, how would we do that with high quality? How would we do that in a patient-centered way? What would that look like? So these are our usual domains that we're familiar with, but we're really trying to reimagine them in a way that makes sense for some of these really difficult locations that are really tempting now to put emergency care right in the center of how their health systems are functioning. And then, of course, time sensitive. We all know the timeliness portion of why emergency care is so important. We're doing a ton of messaging around this, though, and its importance as a keystone within the health system itself. In order to deliver quality, because clearly patients can, if they don't come in a timely fashion to seek care, your outcomes are going to be much worse, which you guys know, but it seems that we need to say that over and over again. And so these issues around access, around quality, around the timeliness of care delivery, the importance that emergency care serves, around that time sensitivity, we're finding those themes that we need to advocate for over and over again when talking about how emergency care fits within health systems themselves. So in moving from emergency care, the definition, as we understand at WHO, into what are the components? So what are the primary functions and the components of the emergency care system itself? Many of you may know this. If you don't, it's a really lovely infographic to show because it shows, one, the complexity of what we do and how we think about things, but also the ways to simplify things into a way that makes sense for people and allows them to really put their mind around a certain location where the care is delivered, or to be able to trace the patient's journey through the different places that they need to go, both from the onset of acute illness and injury through transport and into health facilities, and then on to now, because we're talking about emergency, critical, and operative care now, we have a much more holistic look in the way that we see the world about what that means for the emergent patient. So there has been an enormous amount of work that's gone into this. This probably took about, I don't know, maybe 3 years for WHO to complete, and that was Terry Reynolds' work in this enormous consensus process across every single region of the world to come up with, it's not just this infographic behind this, it's this enormous kind of like Excel spreadsheet with agreed upon primary functions and the various components that are absolutely necessary to make up an emergency care system. And it served as the foundation really for the work that I'm going to talk about with the rest of the toolkit. But just also to say that the framework itself is also accompanied by an acknowledgement of the particular things that you need to make the system work. So that goes with accreditation and where that needs to occur, the system protocols to provide guidance for critical processes, certification for providers to ensure compliance with training standards. And then, we have in the background a number of quality indicators, including time-based intervals that are necessary to really track the system performance. So just a little bit about where we stand with the literature and the case for why emergency care systems are important. Again, I'm not trying to convince you guys. I'm giving you fuel for the fire or ammunition to be able to advocate for this yourselves in the places that you're working. So I would start with the burden of emergency conditions, and injuries is a good place to start, in that we know that injury is very present, especially for policymakers. They see it often. It is increasingly causing an enormous burden of disease. And when you compare it with HIV, TB, and malaria, it has many more deaths per year in the millions. So it's accounting now for nearly 8% of the world's deaths, and 3 out of the top 5 causes of death for injury related for those 5 to 29. Clearly, we see a huge economic burden, costing countries billions of dollars. If you ask kind of what's the general scope, though, of the burden of disease from emergency conditions that could be addressed by better emergency care, there's a number of sources. So many of you all probably have seen the DCP3, the Disease Control Priorities 3, where they're from the World Bank, it says about 54% of deaths that occur in LMICs each year are from conditions that could be addressed by organized pre-hospital and facility-based care. We now have Junaid Razak's paper, as well as Chang's paper, that echo that number in empiric ways in looking at the GBD, ending up about 50% of deaths could be addressed by better emergency care and 43% of DALIs. So quite powerful if we can actually harness the delivery mechanism of a good emergency care system of our ability to remarkably reduce deaths. In the last 2 years, we had a couple of cost effectiveness studies that have come out as well. And so I just want to highlight a couple of those for you. From Charlie Mock's work in pre-hospital care, we know that this is highly cost effective. So all the way on the right, I have the antiretrovirals for HIV costing about $922 for the cost per life year gained. And then you can compare that across different ways of delivering pre-hospital care, both in a staffed community ambulance, which costs about 1/3 of that. You put that into an urban setting, that costs only about $94. And if you train lay first responders and paramedics, the estimates are about $7 for cost of life year gained. We can also look at facility-based care, and these are two of the studies that I'm highlighting for you that have come out in the last couple of years, both from PLOS One and Cost Effectiveness and Resource Allocation Journal. So the first study looked at highly effective basic emergency care using COVID-19 as a tracer condition. And when they looked at severe and critical illness in Kenya and Tanzania, the costs were only $11 to $37 per day. The second study was actually Werner's work that you guys might know of her, some of you who are on this call, who did her PhD in health economics and cost effectiveness. And this took some of the data that from a long implementation process in Uganda and looked at what the implementation of BEC and some of the simple process tools I'm going to show you, what that did in health facilities. It, first of all, was shown to be way less costly and much more effective than standard practice. And it led to some conclusions about the national scale up of the intervention, which was predicted to save 884 lives and $25,000 annually. When you looked at the budget impacts and things like that, the expectation was a 655% return on investment from the implementation of the toolkit that I'm going to talk about very soon. So when we think about where we're going to put this toolkit in, here's probably lots of places where you all are working and where I was working up until December. But we know that emergency units can look quite different all around the world. And so oftentimes when we're pitching the WHO toolkit, we hear a lot of myths and misconceptions. So I highlight them here for you to just bring out a couple of those things that you probably have heard in your work, which is, emergency care is only triage, or it's only trauma cases or road traffic incidents. Lots of times people define emergency care around the case itself. Or I've seen lots of places where they expect that the emergency care is delivered in something completely separate from the rest of the way that patients flow through the health system, or they want to set up separate units or hospitals specifically for that, or that emergency care should only be delivered at a certain location within the health system. Lots of times people argue that triage should only occur during mass casualty incidents. So again, I share these with you to just get your brain working around kind of what are the things that you hear in your work when you're overseas, or even very honestly, when you're working in your US-based healthcare system, because there's certainly a lot of emergency care myths there. So this is some of, again, these advocacy points that I share with you about what we say and what the literature shows the standardized emergency care can do in facilities. And it shows that what we do really matters, right? But I think we sometimes forget that, and we see it in the day-to-day clinical practice. But overall, when we implement it systematically, we know that emergency care can remarkably reduce mortality rates across many conditions and age groups, improve the treatment outcomes, reduce rehabilitation time, decrease the length of stay in the hospital, and really optimize treatment costs. So let's pivot now to just talking about what the WHO Emergency Care Toolkit is. Really, it's about people and training those people and cascading that training. It's about some of the processes that encourage a standardized clinical approach. And it's about information, both its documentation, right, and its analysis overall. And here are the things that make it up. So we usually say it's a minimum of 5 things, and sometimes we expand it depending on what countries want. But the clinical training and the cascade of that training is through the basic emergency care course, which some of you guys may have heard of. We also couple that, though, with the augmentation of how patients move through the emergency unit itself, both with the interagency integrated triage tool, which many places do not have any kind of triage, or they have one that's only used during mass casualty. And we encourage the use of triage in a specific tool that I'll tell you more about. We have lots of structured training around how to design a resuscitation area in the emergency unit. And there's lots of ways that can look. It doesn't have to look like your fancy resus. But we found in the early days of doing this work that in order to really maximize patient outcomes, we were going to need to encourage every resource setting to be able to designate a specific location where the most critically ill patients were cared for. And then our main quality tool the WHO has put forward in the emergency units at this point has been around the trauma care checklist, which has had a good, decent amount of literature around it, both in its efficacy for enhancing process and a trend towards decreasing mortality at different levels of different countries in their development in their emergency care systems. And then from those conclusions, the medical emergency checklist was also created and has had some early data that shows it's been really quite effective in helping to improve processes of care for patients. Then this is the part that's the data collection around the way that we document, number one, with standardized clinical forms. And I'll go into why they look how they do and how they were created. But those standardized clinical forms are basically like the old T-sheets where you could pick up a form that's 1 page and you can kind of like press, like just tick the tick boxes about how the patient is presenting. However, its secret power is that embedded in it, it has the minimum data set for emergency care that's been designed by the WHO and is linked with the WHO clinical registry. Again, I'll talk a bit more about the clinical registry coming up, but it's when we have the clinical registry that's already pre-built for countries, both for trauma care and for any medical emergency, with pre-established audit filters in a way, and it's freely accessible. We train countries on this, and they are actually able to then get a very close look at the quality of care that they deliver in their emergency units. So this is just another look at the toolkit and the way and the places in which we use the different tools. So say reception of the patient, maybe using the triage tool and sometimes basic emergency care. As they move through the emergency unit, you would use some of these other things, but the clinical registry actually spans all the way into inpatient care. And as I mentioned before, this is kind of beyond the scope of today, but we are now really expanding the suite of toolkits to operative and critical care as well. And so again, that's not for today's talk, but just know that we're thinking about the patient in the continuum from the point of illness and injury all the way through definitive care. And WHO is really trying to address each of those steps to maximize outcomes. So let's get into the tools a little bit. You all are probably familiar with the basic emergency care course, but for those of you who are not or haven't seen it taught, it is a 5-day course, and its explicit intent was for use in locations with very limited diagnostics and therapeutic resources. It is open access for frontline care providers to have a systematic approach to the acutely ill and injured. And those of you who have seen this, the modules highlight the approach to the patient, so A, B, C, D, E, and then clinical conditions, so trauma, difficulty in breathing, shock, and altered mental status, with an extremely heavy emphasis on a pretty large number of skills in 5 days' time. I'm going to talk more about the BEC implementation a little bit later and where we've gotten to with that, just as a teaser. This is how we teach it. Often it's been face-to-face, and again, 5 days is a long time to pull people out, though, of clinical rotation, especially since there's often just a few people who are actually delivering care in the emergency unit. We do try to make it as interactive as possible and with tons of skill stations, and then lots of group discussions and breakout groups and things like that. But the reality, especially in the post-COVID era, has been that we really needed to put all these tools up on an online platform that was going to make sense and could be done asynchronously. So just to announce that the BEC learning program is about to be launched on the WHO Academy on June 1st is its intended start date. It is going to be accompanied by a portable learning lab as well. So you would do like the entire kind of knowledge content of the BEC online, and then you would come to just a 2-day portable learning lab to be signed off on the skills and to run through some structured evaluation in order to make sure that you actually knew the skills and knew how to integrate and apply the skills. The interagency integrated triage tool, that is too much to say, so we just call it IITT, is a really fascinating tool. It's gone under many years of development at this point in time. Bhakti can tell you the whole history of kind of like the development of multiple different kinds of triage tools, I know. This has emerged as a consensus product with MSF and ICRC, drew heavily from other validated tools. So if any of you all are familiar with SATS, it has some flavor of that. Or ETAT for pediatrics. So there's a lot of recognizable kind of language in IITT that points to ETAT. There are 4 versions of this. There's adult, pediatric, one for pre-hospital, and then one for during surge conditions. Lots to talk about the validation studies that have been done and things like that. But we're seeing a lot of active uptake of IITT, and even some places that were using a previously validated triage tool who are pivoting to this because they find it very simple in its use. It's 3 different levels. And so quite easy to use, we find, in even the most resource limited settings. I talked to you about resuscitation area designation. I know that we all know why this is important, but this provides some very specific guidance around kind of the space, the material resources, the human resources required, and how best to use that area. So many times people are asking for, what do I need in my resus area? What are the list of medications and equipment that I would need that I know will be in my country? That's the really important part, and that are associated with what we think are going to provide better outcomes for the patients, knowing the types of things that we want providers to do in the resus area or the minimum types of interventions we want them to do. Moving to the clinical checklists. These, again, I had kind of highlighted a couple things that we know about the trauma care checklist and its literature base. Really what these highlight are just key life-saving elements of clinical care, and it helps with a more systematic approach to make sure we haven't missed things, and especially when we're dealing with our most critically ill patients. And so this is not meant for your green patients, this is meant for the red patients. It really takes 2 time points immediately after primary and secondary survey, and then before the team leaves the patient's bedside. And you guys can take a look at some of the literature around this. It's been quite interesting. There was an 11-country study that took a look at the trauma care checklist. And again, across the board, we saw improvements at high income, middle income, and low income countries, having improvements in their processes of care. And again, a trend towards mortality reduction as well in the sickest of patients. Okay, this is what those standardized clinical forms look like. It was an interesting learning point around these clinical forms, because it's boring because it's a chart, right? But I told you its secret power about its embedded data set within it. And unexpectedly, when these were first being pilot tested, it ended up really causing a bit of a change in practice. That was a lot of the feedback that was received in the focus groups after implementation of these standardized clinical forms, particularly in Tanzania. They were prompting junior clinicians, or even ones who just hadn't had a lot of facileness with the approach to the emergent patient. They were prompting them to do their ABCDE approach, and then prompting them to do specific interventions that they had learned in the BEC, but maybe they had forgotten. So they saw this trend to actually improve quality of care, particularly because the chart itself was prompting you to do what the next step was for the patient. And then lastly here, the WHO clinical register. To say a little bit more about that, again, it's on DHIS2, for those of you guys who know that web-based platform. You can look at the data in a single facility view. So if you're working in a location where you think just that hospital really wants to take a deep look at kind of what's happening in its emergency unit, often it's for trauma, but either trauma or medical emergencies, you can just do it in one hospital. That's also fine. But the implications and the intention is that if you can have a national aggregate view, you can really start having this very powerful dashboard to see where things, which hospitals having a higher case fatality rate and why, from what conditions. And again, all these audit filters are already built. So you can see, like I gave you some examples here of case volume by time, EU mortality by time, and specific months. And maybe how that's linked with inpatient mortality as well. So I would also say it has some customizable elements. And so we are actually building a whole module for this, for looking at, say, sepsis care across both the emergency unit and into the inpatient ward, because that's become an increasing priority for the WHO to weigh in on. And so we're building a lot of those things kind of across our various toolkits, and sepsis is now coming into the WHO clinical registry as one of those customizable elements if you wanted to look at that in a single facility or national aggregate view. So here are the core elements again, just in one place. Oftentimes facilities start with, they want to begin, the registry is often a little bit too much. They often want to begin with the BEC and these simple process tools in order to improve the quality of their care. So let's turn to implementation, and then would love to have some conversation with you guys. Here's what we know about impact. I had referenced that we have that PLOS-1 study come out around the cost effectiveness of exactly this implementation. And so let me describe it to you a little bit more. This was done at Mubende and Calvello hospitals in Uganda. And what they did was they collected 1 year of baseline data on key emergency conditions. And so they were considered basically tracer conditions for the care of the emergent patient for a number of different reasons. And many of them were because it was felt that emergency care had a primary role to play in decreasing mortality and morbidity. So pediatric diarrhea, pediatric pneumonia, road traffic incidents, postpartum hemorrhage, and asthma. And then the toolkit was implemented. And then they collected a year of post-intervention data. And they found this really remarkable reduction in mortality at these 2 hospitals. And there's a whole bunch of reasons why, and there's starting to be more literature published about why that was. some absolutely, it was WHO Emergency Care Toolkit. A lot of it was because of its ability to be sustained and the champions who help sustain it. So more to come on that. But just to show you that we know that we have seen this remarkable mortality reduction in particularly resource limited settings with the WHO toolkit. And just to show a couple pictures from that implementation, this was not a fancy place, right? So we weren't building a new facility, we weren't putting in all the things, we were not standing up ventilators. There was designation of a resuscitation area, right? There was the medication equipment associated with that resuscitation area. So you can see the emergency trolley there with the checklist, by the way, on that green card. And they implemented triage, but again, in the most simple of ways. Not a lot of equipment, just 3 different colored cars. And then they had a red bed area. So they didn't have an area that could be made into a fully functioning resuscitation bay, but just the establishment of a location where they were going to put their sickest patients really contributed to the reduction of mortality that they saw in these hospitals. So, and just thinking about how we do the implementation, and that's of such a much longer talk, actually, which Nikofi had very early excellent advice to me when I came to him and said, how should I approach this? So he has been fundamental in our approach and its sustainment. But oftentimes we don't start with a toolkit, right, in countries. And most times we go into countries always upon their invitation, and we partner with the ministries of health, and we do something called the emergency care system assessment that allows us to develop strategic plans with priority actions. And once those priority actions are sent, there's a collaborative process to help the country develop a roadmap of its detailed implementation plans. And then we often are providing a decent amount of implementation support. And increasingly now with the capacity building that we've been doing in regional offices and sometimes in country offices, that is happening independent of headquarters, which is perfect. That's exactly what we want to happen. But this is the approach we take. This is like a little bit of an overwhelming slide, but just to say that we find common gaps or common goals, common gaps that are associated with common goals, and we link those with some of our available tools and resources to be able to help countries make that implementation plan. So you'll see some of the things we've talked about in here already that are contained within the WHO Emergency Care Toolkit, BEC, IITT, the checklists, the clinical forms, clinical registry, but we have a lot more to offer countries. So we now are doing a lot of implementation training around this toolkit. It's not that you don't drop a triage form at the front desk of the emergency unit and walk away, right? We really need to help folks who want to do this understand what the best lessons learned are, and provide some frameworks for thinking about the implementation so that they can come up with solutions that will work in their own context. So we have done trainings both in EMRO, so the Eastern Mediterranean region, Afro region, Euro, and then recently in the PAHO, so the Americas. And then we've done specific national trainings that get much more specific about what folks are, what they're going to do in their own countries, and exactly how they're going to roll this out and what the entire monitoring and evaluation framework is. And we get down and dirty into the details, which makes it really interesting, right? Because especially with the solutions that folks come up with, both in their implementation plans and then in the changes that they make during implementation. So here's some of the purposes of kind of like why we do this training. You guys have got it. But I would say one of the things that's so important that we've seen manifest from these trainings of different regions have been these regional networks, who are now supporting each other in the advocacy for strengthening their emergency care delivery and systems. And even though we started with the toolkit, they're seeing this much bigger role in this kind of community of practice that's regionally organized. And I think that has been really powerful in coming out from the last year of work around implementation training. So here's BEC, just a couple pictures from various places in the world. BEC has now been run in over 50 countries. And if you caught the early part of the communication between Nikofi Bhakti and myself, we are launching tomorrow the BEC 25-25-25 campaign, which is, and this is a initiative that has come out of the Chief Nursing Office and that Dr. Tedros is behind, the Director General. And so there's a big webinar launch tomorrow, and 25, 25, 25 means 25% of nurses in 25 countries to be trained in BEC by 2025. So that is a hugely ambitious goal that, it's really exciting. It's a little overwhelming as somebody who's a master trainer for BEC and knows what it takes to do it well. But it's bringing a lot of attention to the BEC. We have a lot of experience with it. And just to highlight a couple things of what we know about the implementation lessons learned from the BEC, that we can do it pretty well online. And I've given you guys some resources there if you want to take a look at those. But nurses particularly are at greater long-term knowledge loss than when compared with physicians. But we do still remain lots of technical barriers in many places in the world, of course, that longer-term retention of knowledge and skills is really enhanced by mentorship in the clinical environment. And so a lot of our implementation strategies are around, for sustainment, is around that mentorship. And that thing about local champions that I mentioned, that they are absolutely critical to embed the changes in clinical practice. And this is particularly so for nurses. And I guess, yeah, of course, we always need the Ministry of Health to be on board with what we're doing, but we really see the cascade of BEC get a ton of uptake, and we become that kind of powerful wave of transformation in the way emergency care is delivered when ministries are on board. And lastly, to say that the BEC can really be implemented and sustained in even the most difficult of contexts. And I wanted to show you guys this. This is a woman named Dr. Mazda. And as I said, I was working in Afghanistan last year, and this will be my last slide. But we were able, with a lot of help and support from the WHO country office, and then the engagement from this incredible group of master trainers, to train over 500 frontline care providers in less than a year in Afghanistan. And 40% of them were women, which, if you guys have been following the news at all, is a remarkable and difficult feat to do. But we had women like Mazda, who was trained in BEC and the rest of the toolkit, and then went back to her facility and immediately started implementing changes. So just to show you behind her, she created this poster herself. Like, she made it in 48 hours. She sent me a picture as soon as she went back to her health facility. But she's basically talking about the changes that she has made and the uptake that she has had in the WHO emergency care toolkit in her health facility. And then how she has really used it particularly with nurses and midwives, to really change things for female patients who actually can't be touched by men in Afghanistan, especially in some of the most rural places. So I will end there and ask you guys for any questions you have, reflections, clarifications. Would love to hear from you.
Emilie, do you have, if you could, so I know this will come up, are you able to share any of the slides that you presented today? I emailed you on the email I sent as a reminder, so you'll have access to all of the fellows. And the other thing was, for the 25, 25, 25 campaign, if there's anything that you can send our way, I think it'd be great for us to listen in and be champions. Sure. Yep. No problem. Happy to. So does anybody feel like emergency care is now suddenly feasible? Like 10 years on? When you would go to Ministry of Health meetings and people like, what is emergency care? Like, is that the ambulance? What questions do we have for our speaker? And thank you for such an interesting presentation and really showing the evidence behind some of the thinking here. Yeah, I hope that you guys as fellows are actually finding the landscape perhaps a little bit more receptive than many of us did a decade ago, 15 years ago. It really feels like it's changing. It feels that way for a whole bunch of reasons, and I know I have a little bit of a selection bias because now I'm WHO, so I'm having an invitation to come in and discuss. But it's not hard to make the case now, right? I mean, COVID made it so apparent about what the necessity was for emergency care delivery. Injury was already there, and then COVID just made it more apparent. And now we have just all different ways of being able to say how important this is for health systems, particularly. I think I'll do this talk for the fellows next year, but how this aligns with global health security as well and pandemic preparedness. For those of you at AFEM, I gave a talk on emergency care system strengthening for pandemic preparedness and aligning those financial agendas. Maybe there's a question here in the chat. No, lots of thank yous.
I'll throw a thank you in there, and I just great job, by the way. Totally love it. And I was wondering if my dog doesn't tear someone apart, the mailman. But I was just wondering, Emilie, if you could comment on how, if there's support beyond the in-country support, financial support or resource support for implementing the standardized data collection tools across the countries. I've had a couple of groups reach out to me recently about that specific question.
Yeah, so Matt, make sure I get to the heart of your question here, but it sounds from the data collection standpoint, particularly with the registry, that's probably the easiest one to answer.
Yeah.
We have, so we are very happy, and we frequently do. We have somebody whose only job it is to do the registry. And so she is very busy actually doing a number of the trainings and support for data collectors in specific health facilities or across the region. If it's a larger intervention across like a sub-region of the country or the country itself, then we would do it. Oftentimes we would actually come in and do kind of like a training of the trainers course for like the data collectors so that they can then train other data collectors. But our mechanisms are that we often will do that training remotely and then do a lot of support as they're inputting data. And then just for clarity, because people always ask this, the data sits on the server at the WHO, but we cannot access it. It belongs to either the facility, if it's only one facility implementing, or it belongs to the country. And people have different ways, like if you're a country level person, if you're a national planner, actually you get to kind of like see all of things. But if you're like a facility manager, you only see your facility. You don't necessarily see everybody else's unless those permissions are given. So there's lots of ways to be able to use it effectively and be careful about kind of the data management, but it always belongs to the countries specifically.
That's great. And how many countries do you have currently engaged in that? I'm sorry, I think you did mention it in your talk, but.
For the registry itself, there's over 30 countries using it. Of course, we count the countries, like sometimes it's just a couple facilities. Sometimes there are more that are where it's being used. I will tell you very honestly, the biggest limitation we have, I think, to being able to implement that is it is obviously convincing people to document, right? And convincing people to input the data. And a lot of times, depending on the level of the health system and how much intervention we're needing to, how much implementation and what the priorities are around that, sometimes the registry falls to like a second tier. But it just really depends on kind of what the priorities are in country. I just came back from Honduras a couple of days ago, and PAHO has a really amazing capacity around emergency care in a lot of ways. And they're looking to kind of standardize kind of their approach to things. And so places like Argentina and Chile and Honduras really want to take the registry and move forward with it quite quickly. So we see different things being used in different ways.
Matt, I think your question was also around funding. And so if I could answer that bit a little bit, because I think it's important for fellows to realize this. I think WHO itself is a facilitator, a technical lead, but itself may or may not have funding. It may have funding for like certain priority initiatives in hard to reach areas, but funding is also at the regional level as well. So PAHO may have specific funding. The other thing with things like registries, it's really challenging to support funding for implementation of a registry by itself without connecting it to a broader initiative. And so when I look at like the CDC global health security landscape and then USAID and all the work I do on global health security there, the way that I think you can advocate for funding is by connecting the registry to another intervention. So either using the registry to inform a strategic plan or strategy around system strengthening or around informing pandemic preparedness activities. I think that's where like USAID and CDC in particular fund registry work. I have seen some success by the Oxford group who created the ICU registry in getting their I think it's 22 countries now, their registry. That was funded through researchers who said, we're going to implement this registry as a mechanism to inform the aims of and the trials that we are implementing. So like trying to tie the registry as a specific aim within a research project or research activity. The last group that can potentially fund is Ministry of Health, but their funds are often lacking. I've also been able to see that in a lot of countries, World Bank has been really critical at funding these types of initiatives. And, maybe we should get Hynes to come talk to us next time.
Yeah, thanks to both of you. Yeah, this country came, like somebody from a country to me and was like, hey, could you help us set up like a data collection process for something? And I was like, you should use the WHO stuff. That's what I told them. I'm like sent it to them. And, and they were like, well, that was tried. And then we didn't have funding for ongoing stuff. And I'm like, well, similar thing where I was like, you tying it through them and tying it to other initiatives. It does seem like there's this intermediate teenage step, right? Where you can get funding. These countries can get funding to get it launched. This is what happened here. And then they can get funding once it's proven within the country from the Ministry of Health. But there's a teenage growth time where they're not brand new to the process and they don't have quite enough to get their Ministry of Health behind it. And that's kind of where this group had landed. But thank you. I don't want to go over time, but thank you so much, Emilie. Thank you, Bhakti, for your answer as well.
Yeah, absolutely. And just to Bhakti, I just want to make sure I say this in front of this group that I know that you heard at the GACI meeting, which is that there is a new World Health Assembly resolution coming, which is really actually quite exciting for this domain. I mean, we had, in 2019, we had 72.16, which was like really establishing emergency care as critical to universal health coverage. This new resolution is called Integrated Emergency, Critical, and Operative Care for Universal Health Coverage and Protection from Health Emergencies. I won't tell you the consultative experience with the member states about having to pull health security out of the title, Bhakti, but we can talk about that later. But it is explicitly about health security and the ways that integrated emergency, critical, and operative care can actually bring an enormous amount of value to that. So I'm very keen to see it's expected to pass. It's already been through all the necessary steps in the executive board and the WHO side. I think it's going to change landscape for us. It'll take a while, right? Matt, your point is well taken, where it's just interesting, right? Because I don't know, 15 years ago, like nobody was doing a registry, and now we're in this like, well, how do we sustain the registry? Because now people are knowing about the registry, and it's fascinating to kind of watch the arc of this development in a career lifetime. So I think Megan has her hand up.
Hi, yes, thank you so much for such an interesting talk. I love the concept of the BEC Train the Trainers courses and how it can really disseminate the information. I wonder if anybody has looked at kind of as this generational trainers have evolved, whether there's any change in like the content or the fidelity of the information delivered.
Yeah, really good point and incredibly important to bring up. There's anecdotal evidence around it, I will say. I don't think anybody's actually published on that in kind of like what happens 5 generations from your first one. You guys may know that the BEC has a fairly robust certification process in place that involves the International Federation for Emergency Medicine. So if you want to become a trainer, like first you take the BEC and then you do a TOT and then you're a provisional trainer, then you have to have mentor deliveries a number of times by a master trainer to be able to say that you're then credentialed as a master trainer from IFEM. However, again, your point is incredibly well taken, and you should definitely make that your project, because we're going to launch the BEC 25, 25, 25, and there's going to be ample locations to be able to study that, right?
Thanks so much.
Emilie, we just had a study in Kenya that we've completed that showed that the average BEC provisional trainer was training 6.9 other people in our cascade training in Kenya. And that was over a period of 6 months.
That's awesome. That's fantastic stuff.
This was great. Thank you so much. I'm sure everybody's looking forward to the slides. Thank you everybody for joining. We only have one more talk left for this year. So if you're a fellow, please let me know if you think we should skip the next talk or if you're planning to attend. But you should see an invite on your calendars already. Dr. Calvello, it's very, very late. But thank you so much for taking the time to do this. And I think you're right. When I was a fellow, when you were a fellow, when you were a fellowship director, it was really difficult to access this information. And so we're just truly grateful that WHO now has a team of emergency physicians, but then people that we know that are willing to share with us like the path forward.
Yeah, you bet. And please, guys, reach out. And Tegan, I'm looking at you because I need to connect with you anyway about sepsis. So it's reminding me. But yeah, please feel free to reach out because this is really important to have you guys, like not only the knowledge base, but like working out some of these questions in real time. I think is really important for you being the next generation of leaders, and which is exactly what you're going to be. So awesome to connect with you all. And thanks.